understand if you have to give a shot of, say, liraglutide with a shot of glargine. This would be a costly therapy involving 2 injection shots, which many patients would like to take. But I think we are slowly going to that situation where we would be combining a GLP-1 receptor agonist with a basal insulin. Already studies are underway combining liraglutide with degludec, the Liradec study, and as well as a combination. I think a fixed dose combination is, I mean a fixed dose, I wouldn't say, a fixed formulation combination is coming, that is with lixisenatide and glargine. So I think, again, what I find this treatment algorithm is, I think, a little ahead of time. Probably in 2020 we'll be using this too often. So the NICE guidelines, again, and going back, it's a little bit more conservative. Again, they go for sulfonylurea as a first add-on to metformin. But again, if hypoglycemia is an issue, then you can go for the costlier DPP4 inhibitors. So this is the gist of the changing or changed treatment paradigm of type 2 diabetes. We have more or less abandoned the stepwise approach. If you go back to really the, this guideline, you can see at the entry level glycated hemoglobin more than 7.5, they are recommending a dual therapy. Entry level glycated hemoglobin more than 9, either you go for insulin or a triple therapy. So mind it, even 5 years before, 10 years before, it was unthinkable to start with a triple therapy in the treatment-naive patient of type 2 diabetes. Now, at least the ASCE, this is the only August body who has strongly recommended 2 important things. One is classifying patients at entry with glycated hemoglobin, and second, based on the entry-level glycated hemoglobin, you start with either monotherapy, dual therapy, or triple therapy. So the conventional stepwise approach is almost but abandoned, though the other treatment algorithms still advocate that. Early and near universal use of DPP4 inhibitors would be the norm because of certain advantages. Firstly, they have proven to be safe, at least with 6-7 years of use. They are wet neutral, they are orally administered, have no troubling side effects, do not cause hypoglycemia on their own. But only downside till now is the cost of therapy. Now certain controversial generics have come. Well, that is sub judice, I wouldn't go into that. But I can also foresee that in the foreseeable future, the price of these DPP4 inhibitors also are set to come down. So delayed introduction of sulfonylureas. So with the popularity of the DPP4 inhibitors improving, I think we would be using more of DPP4 inhibitors as the secretagogue of choice over the sulfonylurea secretagogues, and that has been actually very strongly advocated in the latest AAC treatment algorithm. For the risk of concerns with bladder cancer, frugal use of pioglitazone. You know, June 2011 had been a landmark date when the concerns of bladder cancer safety came with pioglitazone, and from then on it was all downhill for pioglitazone. We do not know whether June 2013 would be another watershed month for the thiazolidinediones, because the US FDA is reconsidering bringing back rosiglitazone, looking at the safety data, and we are all keeping our fingers crossed whether we would be seeing the resurrection of rosiglitazone. But then liberal use of DPP4 inhibitors in presence of comorbidities, notably CKD and CLD, situations where previously we were using insulin almost mandatory. So this is actually an example of change. therapeutic paradigm. Just you go back to 2006, just maybe 7 years back, a patient of type 2 diabetes, maybe of considerable duration, 5 to 10 years time, rather compliant, taking say maybe metformin, 4 milligram of glimepiride, maybe 30 milligram of pioglitazone and also an alpha glucosidase inhibitor, unable to attain the glycemic targets, yet unwilling to go on to insulin. There we probably would have offered them sitagliptin, then a novel, costly, newly launched DPP4 inhibitor with the hope rather than the conviction that it would control the blood sugar. And in about 50% case patients that worked. But now we are using a DPP4 inhibitor, maybe right from sitagliptin. Now we have vildagliptin, saxagliptin, and linagliptin in the Indian market. Allogliptin is launched in the United States, and in the Japanese and Korean markets, some other gliptins also are there. So, but now we are using a DPP4 inhibitor as a first or second add-on, not maybe as a rescue therapy, so to say, as the fourth or the fifth agent. On the other hand, now probably a patient who is on a 4-drug regimen, maybe metformin, a DPP4 inhibitor, glimepiride 4 milligram or its equivalent, and AGI, not controlled, unwilling to take insulin, we are thinking of starting on a low dose of pioglitazone, maybe for a short period of time before the patient finally agrees to take insulin, not willing to expose the patient to a long period of pioglitazone use. So this is the summary of the incretin-based therapies. I think you all know there are two types of agents, the GLP receptor agonists, exenatide and liraglutide are available, and the DPP4 inhibitors that I've already alluded to. Now there are certain advantages of the incretin mimetics over the DPP4 inhibitors, in that the glycated hemoglobin reduction is probably a shed better compared to the DPP4 inhibitors, especially with exenatide LAR and liraglutide. Weight loss is a definite advantage, but then the problems of the main 2 or 3 problems with the incretin analogs are that they are injectables, which many patients resent. Second, nausea, vomiting may be a limiting factor in at least 20-25% patients, and of course the cost of therapy. I think for our patients, an incretin analog is still restricted only to those subjects who are having diabetes, are morbidly obese, and are motivated enough to lose weight. So more than as an anti-hyperglycemic agent, we are still considering a GLP, despite the recommendations, whatever, irrespective of what the recommendations have to say, we are considering liraglutide or exenatide, especially in those subset of obese diabetics who are motivated and willing enough to lose weight, primarily as an agent for weight loss rather than primarily an agent for glycemic control. Now, so as I said, DPP4 inhibitors have emerged as the secretagogue of choice as an add-on to metformin, or maybe as a monotherapy as the first agent, and they have actually outsmarted the sulfonylureas. Now you may have a question, are these DPP4 inhibitors as effective as the sulfonylureas? Because we have decades of experience with sulfonylureas, starting for chlorpropamide, glibenclamide, and latest glipizide, lactazide, and glimepiride. You see, these are some of the studies. This is a non-inferiority study showing vildagliptin to be as effective as glimepiride over a 1-year period. Now the point is that if a DPP4 inhibitor like vildagliptin is as efficacious in controlling hyperglycemia as a sulfonylurea secretagogue, but without the side effects, significant side effects of hypoglycemia and weight gain. If you do not have the cost considerations in mind, a DPP4 inhibitor naturally emerges as the secretagogue of choice over a sulfonylurea. So this is actually, the comparison of glycated hemoglobin lowering with various incretins. You can see the most impressive one is an agent which is yet to be available, but would be available soon. That is once weekly exenatide. I'm not going into the details. We should not be very parochial in treating patients. Exenatide has some of the advantages, but it has its disadvantages too. About 20% patients have injection site pruritus and swelling and pain. So even exenatide, apparently if you look at just glycated hemoglobin lowering, exenatide may appear to be the best, but then it has its share of disadvantages. And of the DPP4 inhibitors, at least in this study, vildagliptin comes closest in glycated hemoglobin lowering compared to the incretin analogs. As I said, we can also consider DPP4 inhibitors as monotherapy, particularly in situations where probably you would like to use metformin for glycemic control, but for some reasons, either where metformin is contraindicated or there is some serious tolerance issue with metformin. There you see vildagliptin is as efficacious as metformin. So of course this study shows non-inferiority, though there are some few studies showing maybe metformin a shade better. So, and this is of course an add-on. Now as an add-on to metformin, more or less you see the glycated hemoglobin chain is more or less equivalent so far as sulfonylurea and DPP4 inhibitors are concerned. So maybe vildagliptin is achieves similar A1C drop compared to pioglitazone. So I think in situations, as I have said, where you would have loved to use pioglitazone otherwise is a very good drug. Like the DPP4 inhibitors, do not cause hypoglycemia on their own, have a lot of pleiotropic benefits, but then they cannot be used in presence of fluid retention and heart failure. That's one problem. In postmenopausal women, the concerns of osteoporosis are there, and not to speak of the long-term concerns with bladder cancer. So in situations where we would have loved to use a thiazolidinedione, of course, if rosiglitazone comes back, we can use rosiglitazone, but again, the osteoporosis, fluid retention, these are all class effects. Maybe bladder cancer, I don't know. How can we say that it is not a class effect, but then we really have to see. So in situations where we would have loved to use a thiazolidinedione, we can use a DPP4 inhibitor because we have more or less all the advantages that thiazolidinediones have had or had, but without the side effects of, say, osteoporosis, fluid overload, heart failure, and bladder cancer risk. So this is a comparison between intra-class comparison, vilda and sitagliptin. Now vildagliptin, they say, binds rapidly and dissociates slowly, so that the GLP-1 enhancement is throughout 24 hours is probably more robust compared to sitagliptin. This is the study by Marfella et al. Has been often projected in various lectures, though I acknowledge that the number of subjects recruited was small, but at least this is one of the very few studies comparing two DPP4 inhibitors head to head, and that showed with vildagliptin 50 milligram twice daily compared to sitagliptin 100 milligram daily, the GLP-1 levels rise was more sustained with vildagliptin, so So also the suppression of glucagon as compared to sitagliptin. And this is again another study, vildagliptin versus sitagliptin, the Optima trial. Now, basically, without going into the details, the Optima trial tried to show that though the conventional indices of glycemic control, like fasting, postprandial, and glycated hemoglobin, was no different amongst the two agents, the mean amplitude of glucose excursions or glycemic variability was less with vildagliptin given twice daily compared to sitagliptin given once. Now, this glycemic variability is now also the buzzword these days, because now the realization has come that not only sustained hyperglycemia is harmful, but wide fluctuations, peaks and valleys, peaks and troughs are even more detrimental, because the moment you have a glycemic peak, you have an oxidative damage, and that oxidative damage, that oxidative stress can be implicated in the causation of chronic degenerative complications of diabetes, be it atherosclerotic vascular disease, be it microvascular disease. So we would naturally want to have an agent that has the least of glycemic variability. So another thing I said previously, renal impairment, the only drug that we could use with least of concern was insulin, but nowadays many of the oral agents are being used in chronic kidney disease. Notably, one is metformin. Now we do understand is up to an eGFR of 45, you can use metformin. People won't die of lactic acidosis. Even some of the sulfonylurea secretagogues like glyclazide and glipizide can be used cautiously in presence of CKD, so also maybe repugnant. But I think the agents that can be used, the oral agents that can be used with rather safety and lack of concern are the DPP4 inhibitors. Now, which DPP4 inhibitor you would choose, I'll come to that later. So, as I said, DPP4 inhibitors are safe and efficacious in CKD. Well, metformin up to 45 you can give, but beyond that you have to be very cautious. 5-litazone, otherwise not bad, but can add to the fluid overload of renal disease. This I have said. If safety of AGI is limited by the lack of efficacy and GI side effects, because many of the uremic patients are already disturbed by GI side effects, and AGI can only add to that. This is one study, not a very long study, a one-year study showing the safety, tolerability, and efficacy of vildagliptin in CKD. Now, of course, on theoretical grounds, linagliptin is the agent DPP4 inhibitor of choice in presence of CKD, because no dose reduction is necessary. Linagliptin is predominantly eliminated via the liver. But having said that, I think holistically and especially on pharmacoeconomic grounds, I think vildagliptin becomes the drug of choice in moderate CKD and onwards, because here 50 milligram of vildagliptin daily can be given, and that really halves the treatment cost. Saxagliptin is safe in CKD, but in stage 4 or 5 CKD, the safety is not an issue, but efficacy is rather a concern. So I think, to summarize, I think linagliptin or vildagliptin remains the agent DPP4 inhibitor to choose from in patients with CKD. So what do we learn? The treatment, the way we are treating